The reason for this, obviously, is because the volume of information that we're processing as physicians continues to grow exponentially. And a lot of evidence is showing that checklists and memory tools are a very effective way of ensuring that we don't miss things. Even the most intelligent, the most fantastic person in terms of managing literature will struggle sometimes with trying to pass through the volume of data that's out there for us to contend with now as we manage patients. Whenever we can simplify those tasks with checklists and algorithms, it makes the mental work of caring for patients less arduous. Okay. So I have financial disclosures. I have research that's been funded by the Duke Global Health Institute, and Emergency Healthcare Consultants has also received financial support from Sonosite and GE to support our ultrasound training programs. So let's get right into FastHug. This is the initial paper where it came from. It was published in Critical Care Medicine in 2005 by this Dr. Jean-Louis Vincent from Belgium, who's an intensivist. And I have links to these articles in the can pull them up and actually look at them. I think it's very important once in a while for us to actually go back to the origin of some of the tools we use so that you can actually see the thought processes that went into creating them. One thing we do as physicians is that we tend to learn by apprenticeship. So if somebody is teaching you and you just absorb it and continue to use it. And very few of us actually go back and say, well, where is this thing that I'm using coming from? How did we come about with this thing? And sometimes when you take the time to do that mental exercise, it can actually be very illuminating and can change your practice or even the way in which you're using something you've always used. So Fasthugsbids is coming from Critical Care Medicine, and it was published in 2005. And the mnemonic stands for feeding, analgesia, sedation, thromboprophylaxis, head of the bed elevated, stress ulcer prophylaxis, and glucose control. And what, as I was alluding to before, what happened before we started to try to think of a systematic way of assessing ICU patients every day is that things were falling by the wayside, and we found that we were not systematic in ensuring that we manage all the important points per patient. And so this is a very good way for you to kind of have a mental checklist in your mind during rounds that you've covered all the major points when you are dealing with these patients. In the emergency department, when they've been there for 2 to 3, 4 hours, you can go ahead and give your patients a fast hug and just make sure that you've covered all the main points regarding what they need. So let's just go through each of the different points. The first is the feeding. Malnutrition actually worsens outcomes and prolongs ICU stay. Many ICU patients and even our critical patients who present into the ER are already malnourished when they present, and they need daily dietary review. You have to remember that when they're very sick, it's quite likely that they've experienced a decrease in appetite and have probably already decreased their caloric intake 24 hours before they come in to see you. And so many of them are actually already in a negative energy balance by the time they present to hospital. Our sepsis and trauma patients actually require more energy because those processes are very exothermic. They're using a lot of energy. And so for them, you actually have to really pay attention to their energy and calorie requirements because they're using up more than their normal basal metabolic rates. In terms of how we feed, oral is preferable to enteral, which is preferable to parenteral. And when we have patients in the ICU, we want to start feeding and replacing calories as early as possible, preferably within 24 to 48 hours. So when someone presents to critical care, okay, for the first day you're stabilizing them, you don't feed them, it's not the end of the world. But by the second day, you want to start having a very concrete plan for how you're going to actually feed these patients and ensure that they have the energy requirements they need, recognizing that because they're critically ill, their energy requirements are actually going to be higher. And this is why we're emphasizing that once patients are admitted to our HCU ICU, they need a mandatory dietary consult, because as physicians, this is not our scope of practice, this is not our expertise, and we simply don't calculate caloric requirements appropriately. We should allow the nutritionists to do this for us. This is what they've been trained to do. It's important to note that the optimal nutrition needs are still not actually set. There are no gold standards for this, but what we try to do is to do our best and make sure that at least we're replacing as much of what we're giving them and of what they're burning as possible. It's also important to consider micronutrients. So you want to make sure you're thinking about replenishing people's multivitamins, that we're replenishing their the molecules that help us to fight oxidative stress. And so vitamin C and multivitamins are really great to add into the supplements that we feed critical care patients. Fish oils, various types of borage and fiber are usually blended into their meals and added in. So it's not enough to just be giving them pap every morning. You actually have to fortify it. And that kind of information is only available for us through the dietary consultation. Let's go on to the next thing, which is the analgesia bit. And so this is very important. And when we speak to ICU patients who've come out of their admission and survived, they have some very what's happening. And we have no way of understanding what people are feeling and what they're aware of when they're critically ill. We assume that they are unconscious, but actually they're able to perceive quite a bit of what's happening in their environment. And it's really important that we give them adequate pain control. Being intubated is painful. One of the things from the literature that patients report as being one of the most painful experiences in the ICU is actually suctioning. So being suctioned is painful. Dressing changes are painful. And so it's important that we're considering patients' analgesia when they are in the ICU. So it affects their psychological welfare, and it often is poorly addressed in the ICU, particularly because patients are not speaking. We may not be as aware or as cognizant of their pain needs. It's best to put patients on drips with boluses for top-up as needed. Opioids are very commonly used, but we can also use NSAIDs. We can use IV acetaminophen. Ketamine is an excellent thing to add because it is a pain adjunct. It's a dissociative agent. And when you use ketamine, and then you can actually usually then decrease the dose of the opioids that you are using. So these are some of the ways in which we can treat analgesia in the ICU. And then the next thing is sedation. And I want to make the point that you can see that the mnemonic is making a difference between analgesia and sedation. They are actually two separate things. A lot of us think the patient is sedated. Patient can both aspects of their psychology. The sedation needs to actually be titrated very carefully, and it's necessary that we sedate them adequately for uncomfortable procedures like endotracheal intubation, but also you want to be careful when you're sedating because ICU patients can frequently be over-sedated, and it can lead to complications like ICU polyneuropathy. It can cause hypotension. It can cause intestinal dysmotility syndrome, which can lead to ileus, constipation. And so you want to avoid all of those complications, which might lengthen when sedation during the ICU. And this is usually what we're doing when we're dealing with the spontaneous breathing trials. At some point during the day, in the ICU, it's usually happening before morning rounds. The medical officer should go rounds and turn off sedation for not analgesia, but sedation for the patients who are vented or in the ICU about 30 minutes before rounds, so that when the consultant and the team are coming round assessment of their capacity to spontaneously breathe and also their mental status. So you need to have a daily discontinuation of sedation. And this exercise also actually helps us to reduce their ICU length of stay by daily testing out their capacity for spontaneous breathing. The aim of this, it was taken from the article, is to keep patients calm, collaborative, and comfortable. Ideally, for your intubated patients, you want them intubated, but awake and answering questions by shaking their heads and nodding, right? That's perfect. We're not always able to achieve that, but that's actually where you want them to be. And so that's the goal of the sedation and then also the analgesia. When it comes to thromboprophylaxis, this is vitally important. It's often forgotten, but can often lead to significant morbidity and mortality. The rates of deep vein thrombosis in patients in the ICU who don't receive prophylaxis can range anywhere from 13 to 31%. If you think about that statistics, that means a third of patients in the ICU are at risk of developing DVT and eventual pulmonary embolus, which can lead to massive complications. They are already immobile. Many of them are coagulopathic. So they've already actually fulfilled many of the criteria for Vercoe's triad. And so we need to really think about DVT prophylaxis in the ICU. Typically, we're using a combination of pneumatic compression and sub-Q enoxaparin, which is the easiest thing to do in this environment. Some places also use IV heparin. I've not seen that a lot in Nigeria because if you're using IV heparin, it requires continuous and very regular checks of the coagulation profile so that you can adjust the heparin infusion. And so usually it's easier to just do enoxaparin. I want to make a point here that TED stockings are ineffective. I know we put them on and we feel we are doing something, but we should actually recognize that when we are giving patients TED stockings as DVT prophylaxis, we are treating ourselves and not the patients. This is not an effective way to prevent DVTs in critical care patients or frankly, any patients in the hospital. The next thing is to have the head of the bed elevated. This is vital. We think of this with stroke patients, but actually all ICU patients need this. You want to keep the head of the bed at 45 degrees at least, particularly for mechanically ventilated patients. And also reduces the risk of aspiration and eventual pneumonia. So when you're going through on your rounds on a daily basis or however frequently you do your fast talk, you want to look at it and say, okay, what's the feeding? Have we started feeding? Has the dietary seen them? Are the usually we're doing an opioid. Fentanyl is the one of choice because it has a short half-life and is quickly off once you turn it off. What's our analgesia plan? A lot of times we're doing propofol or midazolam. Have we done anything about DVT from prophylaxis? Is pneumatic compression on? When was their last dose of sub-Q enoxaparin? And what about the head of the bed? Please make sure that they're sitting upright in bed and that the head of the bed is up. Next is the stress ulcer prevention. This is vitally important. In case you don't know, being in the ICU is an extremely stressful event for patients, and they're quite prone to stress ulcers. And it's important, especially for all ICU patients, but particularly for coagulopathic patients, patients who are vented or non-invasive, patients with respiratory concerns, and patients especially who are on steroids. And many of our ICU patients are already on steroids. This increases the risk of GI hemorrhage. You can imagine the worst thing that could happen is to have a patient who's already quite ill, maybe has a very significant sepsis, and then on top of that, because we didn't do stress ulcer prevention, they develop, an upper GI bleed or something and start having significant hemorrhage and instability. So you want to make sure that you are doing the best you can to prevent this outcome. It's good clinical practice. We can use H2 blockers or PPIs. Things like sucralfate are not useful. They're really quite an old drug, and cimetidine are things that are really falling out of favor. Maybe they were used in the past, but we have better agents for this now. We have ranitidine, we have omeprazole, we have esomeprazole. And so any of those agents would be good. And typically we're giving it either as a continuous infusion if somebody is really ill with an actual GI hemorrhage, or as dosing on an intermittent basis every day. So this needs to be addressed. The last on this fast hug is the glucose control. We're just seeing that close glycemic control is very helpful for patients in the ICU. It decreases their ICU length of stay and reduces their mortality. The aim is to try to keep the glucose below 150 milligrams per deciliter. And we're typically using an insulin sliding scale, which is titrated according to the patient's needs, a low, medium, and high scale. And then other anti-hypoglycemic agents. And so you need to think about good glucose control for the ICU patients as well. So that was the first iteration of this, the fast hug. And the article was actually called, Give Your Patients a Fast Hug Every Day, at least once a day. And so this is how we first started. Now, fast hug. So we had fast hug, and then we added SBID, spontaneous breathing trial, a bowel regimen, indwelling catheter removal, and de-escalation of antibiotics/drugs. And this was the supplement, which was a response to an article where the initial author of Fast Hugs, Jean-Louis Vincent, wrote a letter into critical care medicine asking that his initial mnemonic be modified to include these new guidelines, because he realized that there were some additional things he needed to add to the initial mnemonic. So let's go through the new 4 elements that came up in 2009. So we have the spontaneous breathing trial, highly effective in assessing patients in terms of how we want to wean them. We need to remember that oxygen itself is a drug and can cause significant brain damage when we administer it at too high a level. So as I was saying before, you want to turn off or decrease the sedation at least about 30 minutes before your breathing trial. Ideally, you want to do this just before your daily rounds. And then you want to give the patients a chance to see how well they can do on their own in terms of breathing without assistance from the vent. What does this mean? It means that if a patient perhaps is on a pressure support mode or an assist control mode, you put them on CPAP and just see how they do. If a patient is on CPAP, you might maybe turn off the positive pressure for the period of the breathing trial and see if they take any spontaneous breaths on their own. You might take the machine off of the tracheostomy, and just put the T-piece in and see how they do, and see whether they can actually take any spontaneous breaths. So wherever they are, you basically de-escalate to the level below and see how they can do with support on their own. It's also very helpful if you can to time the ABG during this trial, so we can compare how they're doing with support versus what they're doing on their own. And this kind of information is very helpful as we're trying to assess the respiratory capacity of your critical care patients. This has to be highly protocolized and performed daily. And it's something that is done with a guideline, which we have not actually written up in our ICU, but we do have very experienced consultants, and we'll be writing out guidelines for how these spontaneous breathing trials should happen on a daily basis so that we can perform them on our ICU patients. Prolonged mechanical ventilation is detrimental. It increases the risk of vent-associated pneumonia, causes tracheal stenosis, can cause all kinds of issues to the vocal cords, make repeat intubations very difficult. Patients who've been intubated for a prolonged period of time actually harder to intubate the next time you have to intubate them. So it's very important that we actually think about doing this in order to get our patients off mechanical ventilation as soon as possible. On the issue of the bowel regimen, vitally important. Another thing that we forget about when patients are critical, but it's important. You have to think about pooping and all those sorts of things as well. Your bowels must move. And the disorders of the GI tract are extremely common in ICU patients. They frequently develop ileus, a paralytic ileus, which can lead to a pseudo-bowel obstruction. They can have constipation, which leads to patient discomfort, feeding intolerance, and delirium. And they can also develop significant diarrhea that can cause anemia and electrolyte imbalance. Pooping. Have we seen any bowel movements? Are they if they are having diarrhea, you also have to treat that aggressively. And so institutional standards and definitions for our units are going to be coming up soon. We need to decide what we consider to be ICU-associated constipation and what we consider to be ICU-associated diarrhea, and treat it accordingly based on guidelines for the unit. The reason I'm talking about guidelines, we will make mistakes, and the less we will miss things in our critical care patients. Indwelling catheter removal. We just had a patient in the ICU who continued to spike fevers. And one of the things we did as we were trying to figure out what was going on with her is that we changed all of her lines. Our central line was changed, our arterial line was changed, our urethral catheter was changed. These things are plastic, they're piercing their skin, and they're going directly into very sterile cavities within the body. They can get infested with bacteria and other microorganisms. And so you want to be thinking about your indwelling catheters whenever you have patients in the ICU for a while. They should be assessed daily and discontinued once they are no longer needed. For the unit, we want to start changing our centrals and arterials over a wire every week. You want to make sure that you're changing the Foley's weekly, especially if you're using the old type instead of the new silicone type, which doesn't have which prevents bacterial infestation. And the tips should be sent for culture so that we can begin to develop antibiotograms for the kind of bacteria and bugs that are growing in the ICU and their resistance profiles. So please think about this on a daily basis during rounds in terms of which catheters, which indwelling Foleys are still required in your ICU patients to prevent infection, worsening of sepsis, or any kind of worsening of their systemic condition. Then the de-escalation of antibiotics and drugs. This is also very important. Do you need to keep them on this drug? So every day you want to think about that. If you have the culture results back, do they still need to be on broad spectrum antibiotics? Can you de-escalate and go to something that's a little bit more targeted and focused on what is growing in their culture? You also need to think about this for other drugs. Do they still need sedation? Do they still need analgesia? Do they still need to have parenteral TPN? Can they be switched to NG tube feeds? You want to be thinking about each of these things for every aspect of your patient and thinking about the things you can take off. The less we are supporting them, the more likely they are to leave critical care and be de-escalated to regular wards. For the feeding, you want to switch from parenteral IV to oral, whether that's them taking it or through an NG tube as quickly as possible. Using the gut to feed a patient is just vitally miles better than any TPN that we can give. TPN itself is a problem. It is formulated with egg. It frequently gets contaminated and infested with bacteria. You have to use it within a specific period of time, and it's just very difficult to give and give sterilely. And so, as much as possible, you want to avoid going down that route for your patients. Then, Fasthugsbids became Fasthugs in bed, please. So this is the third iteration coming out of an intensivist, I think is in New Zealand, who has kind of decided to modify it in this way. This can be found in one of my favorite blogs, Life in the Fast Lane. It's just a fantastic blog from this doctor that talks a lot about emergency and critical care topics. And so we've already talked about Fasthugs, and then he's actually changed it to In Bed Please, which is indwelling catheter, nasogastric tube, bowel care, the environment. Have you thought about temperature control, the lighting? We never think about lighting in the ICU, but it's actually shown in studies that a lot of ICU patients have delirium and sundowning because a lot of units were not built with windows. The sun sets our circadian rhythm. Your body knows to wake up and sleep with the sun. And when you put patients in a dark unit with no sunlight and no windows, guess what? They get delirious over days and they start bucking your vents and going crazy and trying to pull the wires. So in our ICU, we have windows, which are asked for specifically. Open them during the day, let the sunlight in, let the patients have the light, close them at night, turn the lights down. You don't need to have the fluorescent light on all night long. Simulate nighttime, simulate daytime. It helps to keep the patient sane and prevents ICU delirium. De-escalation of as many things as possible. We talked about drugs and antibiotics, but this is also the time for you to think about your daily family discussions. You want to update the family with a very targeted and very honest assessment of what is happening with the patient. Good morning, sir. Your wife is in the ICU. She's vitally ill. She can die at any moment, but we are doing our best. She's alive for now. This is what we are doing. We are giving her this medication. She has a significant infection. She still needs the intubation. She still needs the ventilator. She still needs all of these drugs. Today, we and you keep the family up to date, because if you don't do that, 2 days later, when she's coding, they are furious at you. You never updated them, and as far as they knew, she was getting better, and you never told them otherwise. So the daily family check-ins are very important. In the ER, making sure you make the time after you've gone through all your madness, chest tube, ventilator, whatever, to sit the family down and say, okay, this is what we just did. This is why we did it. And this is why it was important to do. Then psychosocial support for the family, for the staff, for the patients. The staff in emergency and critical care also need a lot of support. We're dealing with a lot of life-threatening and very serious conditions. We are the providers. We are taking on a lot of injury to our mental status. And we need to also make sure that we're thinking about that. I'm not always the best with ensuring that debriefs happen, but please, we should try to institute a debrief culture where after things happen that are very serious or bad or deaths, the team takes time to sit down and debrief and just make sure everybody is aware that it is okay to feel bad and that we just have to pick ourselves up and move on to our next patient. For analgesia, the fast hugs in bed please has been modified to also include antiemetics and your vaccinations. So your tetanus booster, your diphtheria vaccine. For your elderly patients, you want to be thinking about things like pneumovax and other vaccinations that might be important to prevent long-term injury and disability. So this is the kind of evolution of this pneumatic. And what I'd like to see is that in the ICU, we are using it. We have been on our daily WhatsApp when we have a patient. The doctor on duty does send us a Fasthugsbid assessment every morning to update us about what is happening to the patient. And I would like that practice to continue. You need to apply it daily. As I said, these mnemonics are very helpful ways for us to run through the mental checklist of what is required for each patient whenever we are managing them in critical care spaces, including the ER, because critical care starts from your emergency department. That's where the centrals get placed. That's where the intubation happens before we transfer them to the ICU. Some amazing critical care forum resources. Forum is, free online medical education. I find this useful. mcrit.org is fantastic. It's curated by Scott Weingart. He's the god of ED critical care and one of my teachers and mentors in residency. It's just chock full of information. You can access it for free. And if you have some money, you can actually pay for a subscription and get some extra material from them. And then, as I mentioned, Life in the Fast Lane from the intensivist in New Zealand also has a lot of great things where you can really just Google things around some of the things that you're seeing. It's important to keep these critical care online resources in your back pocket. We do have textbooks, but textbooks are already outdated as they're published. And they're usually about 10 years behind what's happening at the forefront of your field. So it's nice to have a textbook to read to kind of get the basics, but you need to have something that you're referencing to ensure that you are keeping up to date on current practice. And of course, for those of us at RJLAD, we now have access to up-to-date. Activate your up-to-date subscription. Up-to-date also has a lot of great information about some of the topics we've talked about today: ICU delirium, how to prevent bowel dysmotility syndromes, and then also a lot of patient and family information sheets up-to-date that you can print to give to family when they're asking you what something means, that they can read for their own information and education. So our emergency HDU ICU service is one unit, one service in a continuum. The ER is a 3-bed unit. It opened in March of 2022. The HDU is a 3-bed unit. It opened in July of 2024. We're currently a bit down because of our mobility issues, but our unit is still very much open and taking admissions. And then we have a 6-bed ICU that we're yet to open, but we're hoping will open by the end or middle of next month. Lots of growing pains, but our service is trying to stabilize, and we are adding to critical beds available in Lagos and in Nigeria in general. There is a critical shortage of not only ICU beds, but even worse in the HDU space. And then, of course, critical shortage of intensivist and critical care staff. So what we are doing is really contributing very vitally to the healthcare needs of the nation. It's staffed 24/7 by a combination of Econ and RJLAD staff, of teams of nurses and doctors, and we are adding to that team every month. We are having a new set of lead ICU nurses resuming in September that are extremely skilled, and we will be able to then have a morning and night manager on duty 24/7. Here are the references for some of the material I talked about. So the first article on give your patient a fast hug once a day, the initial article, the modification to the updated mnemonic that came out in 2009 from the same doctor, and then Life in the Fast Lane with their fast hugs in bed, please modification, which you can access from this URL. So at this point, I'm going to stop and take any questions that have come up in the audience. It's a very simple topic. It's simply to help you think about a systematic way to manage your ICU patients. And I thank everybody for tuning in and listening. Thank you. And if there are no questions, we can always end things. We don't have to wait.
There are questions.
Okay.
And there will be contributions too. Do you mind if I start by contributing from here? I'm Dr. Ojifini. Thank you so much, Dr.
Please go ahead.
Great presentation, as always. A great teacher indeed. And you simplified it for us so that we can really follow it, even historically, to know that it used to just be Fasthug and then the other things that were added. I just want to re-emphasize, especially for the purpose of my residents, that please never assume that because the patient is unconscious, they cannot feel pain. We should never assume that. And I heard Dr. Fashonayola saying that repeatedly. And that's the reason why we talk about analgesia. Any patient who is intubated, and I thank you, ma'am, for mentioning the fact of suctioning. I won't forget that. Suctioning can be very, very painful, can be very, very discomforting. So please, let's never forget to put the patient at ease by making sure that we give analgesia. I just have a quick question. I was managing a patient in ICU one of those days, and I got a call from a resident, a doctor in the US. And while we're trying to switch the patient to make sure that we wanted to be sure that she can actually have a spontaneous respiration. So we switched the patient from SIMV to CPAP from time to time. The doctor felt that no, we shouldn't do that. That a patient should never be asked to wake up from sedation when they're in ICU. I didn't have time to do a lot of arguments, so I just listened to what the person had to say and went on with what I know is correct. Just to say that, is that correct? That a patient is intubated, ventilated, and you leave the patient on for days without trial or spontaneous respiration. And maybe at best, just give the patient some analgesia and just a little bit of sedation. Of course, when you're doing that too, I don't think that you should be giving the patient sedation. So he was almost like scolding us for not giving the patient sedation, for trying to bring her out of bring her to have some spontaneous respiration, because to put her on SIMV because of severe sepsis. I would just like to have you speak to that. What do you think about what that person was proposing and the practice that he did then? Thank you.
It's wrong. As soon as possible, you want to start spontaneous breathing trials. We can't keep patients. It's one of the first mistakes I actually made when I was a new intensivist, especially coming from the ER, where our perspective is to keep the patient calm. So the ER doctor means like sedate analgesics with no stimuli. But for intensivists on a long-term basis, you want to actually start the spontaneous breathing trials as soon as possible. And for the spontaneous breathing trials, analgesia can continue, but sedation should lighten. And you want to try to do them every day. And there's a lot of evidence now to support that. So I would say, in response to that, doctor, if you have to discuss it with someone again, to just let them know it's not supported by the evidence. We are encouraged to do spontaneous breathing trials with the patient as soon as you think that they're stable enough to start doing it. So I'm not suggesting that your patient just came into the ICU and things are still going haywire, alarms are still going bang, 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 and you start spontaneous breathing trials. That's not the right time. But once you have them kind of at a plateau where things have kind of settled into place and you're beginning to think about the long term, you want to actually start treating this kind of thing to see about weaning them off the vent. You can't take somebody from SIMV at 40% and the next day just turn it off and say, give it a go. You have to wean them down, and you have to actually see how well they're doing on a gradual basis before you go all the way. And I see Dr. Jedoyin has his hand up. He's one of our intensive care doctors. Sir, please go ahead and chime in about what you think.
Thank you for the answers.
Yeah, thank you very much, Ma. Thank you very much for this wonderful presentation. In fact, you make the life so easier for everybody to.
You're breaking up though. We can't hear you.
Can you hear me, Ma?
You're breaking up, but we can hear you. It's like you're
okay, sorry. Okay, Ma. So also, I want to say that the issue of the fast dog is also evolving, as you said. We might reach a point too where we will also be part of the people that will contribute to the next phase of this fast dog. So let's keep our mind open on that. Sorry, on Dr. Givini's question. What I know about the question you raised is that it depends on patients. There are some patients that will intentionally induce coma in ICU. Especially many of these are patients that really have raised ICP. You actually want to keep them close to basal metabolic rate as much as possible. You technically want to paralyze them, want to sedate them, and place them purely on mechanical ventilation for some days, not for a very long time. Just for you to be able to see that this rate ICP is down significantly or is coming down. It has been shown to actually improve the outcome in some of these patients that are severely head injured. However, there's a very thin line between you actually taking this patient down and tilting them to another thing, like VAP, not even getting them into drug toxicity and all those things. So it's a very, very thin line. In my practice here, we have tried it and we saw how bad electricity and a lot of things has dealt with us. So we stopped actually paralyzing patients and taking them down completely. We go for trying as much as possible to get our patients off sedation and trying to see how quick they can breathe. So for us, I would still want us to stick with what we do. In US or wherever they are, they can do what works for them. If they have all the facility, they can monitor the drug in the system. They can have a very close tab on the incidence of the VAP and all those things. So that's my contribution on that. And also, on the issue of analgesic in ICU. Yes, as you said, a lot of medications can be used, but NSAID is one of the drugs that we must be careful with. Aside it worsening the incidence of stress ulcer, which our patient are already predisposed to, it actually has also been incriminated in the incidence of AKI in ICU. So we have to be careful with it. It's actually not recommended that we put a patient on NSAID for more than 5 days in ICU. I think the one they've extended to about 7 or 10 days was ketorolac, I think. So NSAID, we must be very, very careful with its use in ICU. Thank you very much. I hope we heard me. Thank you.
Yes. We did. I think so. And I want to buttress Dr. Ojedoyin's point. I remember as a resident, when I was working with Scott Weingart, he used to tell me that paralytics were for the lazy doctor. That when we're going ahead and giving VEC, we're lazy. He said what you should be doing, especially when they're intubated, and then you're not worried about an airway issue, is you should be optimizing your sedation and analgesia for the comfort of the patient. Because what you're doing with vecuronium is you just paralyze them. So you don't know when they're in pain. You don't know what their status is. You just paralyze them. So for him, vecuronium was very much a last-ditch thing. And so to just buttress Dr. Ojedoyin's point, we do quite a bit, of course, in some of the patients when they're just really difficult to ventilate, but it should not be a routine thing. What you should be doing is trying to optimize the analgesia and the sedation. Though you need to be careful when they're not intubated so that you don't make them so sedated that they can't spontaneously breathe. So it's a thin line we're walking, trying to find the best line to walk. Thank you so much, Dr. Ojufini. That was a great question. Further questions from the team? Or comments from other doctors? Can speak to your experience, what you've seen in the ICU. We still have about 10 minutes to go on the designated time for the lecture. Okay, if there's nothing, Dr. Ojufini.
Thank you so much, Dr. Fashinayala, for the wonderful presentation. Like I said, my residents are here. They're all fully there. And I want to say thank you also on their behalf, because I believe you also did this presentation for their sake. There is just a thin line, or maybe just a little difference in the way we look at this in the emergency department, because more often than not, our patients are acute and critical, as opposed to chronic and critical that we see in the ICU or high dependency unit, as the case may be. So thank you so much. I know we've learned a lot from this, and we can adapt it even to our known environment as well. Thank you very much, man.
All right. Thanks, everybody. Thanks for joining. I will make the PDF of the slides available and share them widely. And please try to apply the Fasthugsbid to your patients when you're rotating through the ICU, and even in the ER in the acute phase. After you've managed them and stabilized them, you want to think about the Fasthugsbid then, to make sure that you've covered all the checkpoints for your recently intubated patients. Oh, hello, everybody. Hi, guys. Wonderful. Oh, you're all there. That's great. Thank you, ma'am. And Dr. Getia too. Hello. All right. That's all I've got. Thank you. See you next week for the next lecture in this series on critical care, where we'll be going over oxygen administrations and ABGs. Yes, ma'am. Thank you.
Thank you, ma'am. Thank you, ma'am.
Bye-bye.
I don't trust you.